Discuss about drugs for cough. First of all, let us discuss what is cough. Cough is a protective reflex and its purpose being expulsion of respiratory secretions and foreign particles from the airways. It occurs due to the stimulation of mechano or chemoreceptors in throat and respiratory passages or stretch receptors in the lungs. The commonest cause of acute cough, which will last for less than 3 weeks, is the respiratory viral infection. So let us first discuss the classification of drugs for cough. They are categorized into the main types are pharyngeal demulcents, expectorants, antitussives, and adjuvant antitussives, under which are bronchodilators. First, examples of pharyngeal demulcents are lozenges, syrups, glycerin, licorice. And expectorants are again categorized into two types, secretion enhancers and mucolytics. Examples of secretion enhancers are potassium citrate, potassium iodide, guaifenesin, toloplasm, balsam, Vasaka, ammonium chloride. Coming to mucolytics, the examples are bromohexane, ambroxol, acetylcysteine, carbocysteine. And coming to antitussives, which are nothing but cough center suppressants, they are categorized into opioids, non-opioids, and antihistamines also come under antitussives. Examples of opioids are codeine, ethyl morphine, and folcodeine. Coming to non-opioid antitussives, examples are noscapine, dextromethorphan, chlorpheniramine. Examples of antihistamines which act as antitussives are chlorpheniramine, diphenhydramine, and promethazine. To be more precise, the antihistamines can be used as adjuvants because they don't have the direct suppressant effect on the cough center. Now coming to adjuvant antitussives, they are bronchodilators. Examples are salbutamol and terbutaline. These are the various drugs for cough. Now coming to the etiology of cough and the treatment approach. Etiology means cause of the cough and the treatment approach, which is nothing but the therapeutic management. So if you have upper or lower respiratory tract infection, that is the cause of the cough is upper or lower respiratory tract infection, then the appropriate treatment approach is use of antibiotics. If the cough is due to smoking or chronic bronchitis or bronchoectasis, the treatment methodology should be cessation of smoking, avoidance of pollutants, steam inhalation, and post-oral drainage. If the cough is due to pulmonary tuberculosis, treatment approach should be antitubercular drugs. If it is asthmatic cough, the drug of choice are inhaled beta-2 agonist, corticosteroids, or ipratropium. If the cough is due to pulmonary eosinophilia, treatment approach involves diethyl carbamazepine citrate and inhaled corticosteroids. If the cough is due to postnasal drip due to sinusitis, appropriate treatment approach is antibiotics, nasal decongestant, H1 antihistaminics. If it is due to postnasal drip due to allergic or perineal rhinitis, avoidance of precipitating factor, corticosteroid nasal spray, and H1 antihistaminic are the drug of choice. If it is due to esophageal reflux, cough is due to esophageal reflux, then bed head elevation, lighter dinner, diet modification, H2 blocker, proton pump inhibitor, and mosapride should be included. If the cough is due to ACE inhibitor associated, then substitute ACE inhibitor by angiotensin receptor blocker. NSAIDs may reduce the cough. If it is post-viral cough, no specific treatment, it subsides itself. These are some of the etiologies of cough and the various treatment approaches appropriate for that particular etiology. Now let us discuss the definitions of demulcents and expectorants along with antitussives. First of all, demulcents. What are demulcents? Pharyngeal demulcents soothe the throat and reduce the efferent impulses from the inflamed or irritated pharyngeal mucosa. Thus, they provide the symptomatic relief in dry cough arising from the throat. Now coming to expectorants. Expectorants or mucokinetics are the drugs that are believed to increase bronchial secretions or reduce its viscosity, facilitating its removal by coughing. Coming to mucolytics, they extend their effect on the mucus layer lining the respiratory tract with the motive of enhancing its clearance. When it comes to antitussives, they act in the CNS to raise the threshold of cough center or act peripherally in the respiratory tract to reduce the tussle impulses, or both these actions. Coming to expectorants or mucokinetics. As we have discussed earlier, they are considered as secretion enhancers. These are the drugs that are believed to increase the bronchial secretion or reduce its viscosity, facilitating its removal by coughing. Examples are sodium and potassium citrate are considered to increase the bronchial secretion by salt action, whereas potassium iodide is secreted by bronchial glands and can irritate the airway mucosa. So prolonged usage can affect thyroid function and produce iodism. Now coming to another drug, guaifenesin, Vasaka, Tolu balsam are plant products which are supposed to enhance the bronchial secretion and mucociliary function while being secreted by tracheobronchial glands. Ammonium salts are nauseating and they reflexly increase respiratory secretions. These are various examples and their specific mechanism of action of some of the expectorants. Now let us discuss about mucolytics. First drug is bromohexane. It is a derivative of vaccicin. It is a mucolytic and mucokinetic capable of inducing thin bronchial secretion. It depolymerizes mucopolysaccharides directly as well as by liberating liposomal enzymes. And the network of fibers in the tenacious sputum are broken. Because of that, the network of fibers in the tenacious sputum are broken. Coming to the side effects of bromohexane, the side effects are rhinorrhea, lacrimation, nausea, gastric irritation, and hypersensitivity. Dosage is adult 8 mg thrice a day. Children from age 1 to 5 years 4 mg twice a day. For 5 to 10 years it is 4 mg thrice a day. Dosage form of or marketed preparations are bromohexane 8 mg tablet or 4 mg per 5 ml elixir. First drug is ambroxol. It is a metabolite of bromohexane having similar mucolytic actions and side effects. The dosage is 15 to 30 mg thrice a day and the dosage form are Ambril, Ambrolite, Ambrodil, Mucolite 30 mg tablet, 30 mg per 5 ml liquid, 7.5 mg per ml drops and Acocontin is 75 mg CR tablet. The next drug is acetylcysteine. It opens the disulfide bonds in the mucoproteins that are present in the sputum and makes it less viscid. The dosage is, it can be administered orally in the dose of 200 to 600 mg thrice a day and by inhalation, 10 to 20% nebulized solution. In intubated patients, by instillation of 10 to 20% acetylcysteine solution directly into the respiratory tract. Coming to the marketed products or dosage forms are Mucotab 600 mg tablet, Flumicil 200 mg tablet or 600 mg effervescent tablet. Mucomix is 200 mg per ml injection in 1, 2 and 5 ml ampoules. The next drug is carbocystine. It liquefies viscid sputum in the same way as acetylcysteine. The dosage is 250 to 750 mg thrice a day. Side effects are gastric discomfort, rashes, and it is contraindicated in peptic ulcer patients. Marketed products are Mucodyne 375 mg capsule or 250 mg per 5 ml syrup. Carbomox, which is nothing but carbocystine 150 mg plus amoxicillin 250 mg per 500 mg capsules, or it is also used as Carbicef, which contains carbocystine 150 mg plus cefalexin 250 mg. Both together they comprise 500 mg capsule. Now, mucolytics are specifically useful in patients with tracheostomy, asthmatic bronchitis, cystic fibrosis, etc., who have thick, tenacious sputum or mucus plugs. Now, coming to antitussives, these drugs they act in the CNS to raise the threshold of the cough center or act peripherally in the respiratory tract to reduce the tussle impulses or perform both these actions. They are of two types, opioid antitussives and non-opioid antitussives. Coming to opioid antitussives, first one is morphine. Morphine and its congeners are most effective antitussives, but morphine is not suitable for treating cough due to its addictive and depressant property. The next drug is codeine. It is qualitatively similar and less potent than morphine, but is more selective for cough center. It is a standard antitussive and suppresses the cough for about 6 hours. The antitussive action is blocked by naloxone, indicating that it is extended through opioid receptors in the brain, and in certain antitussive action can be dissociated from the analgesic addicting action. Side effects are constipation, respiratory depression and drowsiness. Dose 2 to 6 years. For 2 to 6 years old it is 2.5 to 5 mg, and for 6 to 12 years old it is 5 to 10 mg or 10 to 30 mg thrice a day. Dosage form is codeine, which is nothing but 50 mg tablet or 15 mg per 5 ml Linctus. The next drug is ethylmorphine. It is closely related to codeine and has antitussive and respiratory depressant properties, and it is less constipating. The dosage is 10 to 30 mg thrice a day. Dosage form is dionendone, which is 16 mg tablet. The next drug is folcodeine. It is similar in efficacy as codeine and it is longer acting for 12 hours. The dose is 10 to 15 mg. Now coming to non-opioid antitussives, the first one is noscarpine. It is an opium alkaloid of benzoisoquinoline series, which depresses cough and has no dependence inducing properties. Useful in spasmodic cough. The side effects are headache and nausea. Dose is 15 to 30 mg. In children 2 to 6 years, it should be given as 7.5 mg, and for 6 to 12 years it can be given up to 15 mg. The dosage forms are, or marketed products are, Coscopin 7 mg per 5 ml syrup and Cosco tabs, which are 25 mg tablets. The next drug is dextromethorphan. It is a synthetic central N-methyl D-aspartate receptor antagonist, and D-isomer has antitussive action. Side effects are dizziness, nausea and drowsiness. The dose is 10 to 20 mg, and for 6 to 12 years old it can be given from 5 to 10 mg, not advocated for children less than 6 years. The next drug is chlorpheniramine. It is centrally acting antitussive, weak antihistaminic. It is a centrally acting antitussive and weak antihistaminic, anticholinergic and local anesthetic properties. The onset of action is slow and the duration is longer. The side effects are dryness of mouth, vertigo and irritability. The dosage is 20 to 40 mg. The next drug is prenoxadiazine. Prenoxadiazine. It is an antitussive, acts by desensitizing the pulmonary stretch receptors. The dosage is 100 to 200 mg thrice a day. Dosage form is prenoxid, which is available in 100 mg and 200 mg tablets. Now coming to antihistaminics, they afford relief in cough due to their sedative and anticholinergic actions but lack selectivity for cough center. They have been specifically promoted for cough and respiratory allergic states. The drugs are chloramphenicol in the code range of 2 to 5 mg, diphenhydramine 15 to 25 mg, promethazine 15 to 25 mg are commonly used. The marketed form or dosage form is Phenergan, which is 5 mg per 5 ml elixir. The second generation antihistamines like fexofenadine, loratadine are ineffective to suppress the cough. Now coming to bronchodilators. Bronchospasm can induce or aggravate the cough, and the stimulation of pulmonary receptors can trigger both cough and bronchoconstriction, especially in individuals with bronchial hyperactivity. So, bronchodilators relieve cough in such individuals and improve the effectiveness of cough in clearing the secretions by increasing the surface velocity of airflow during cough, and they should be used only when bronchoconstriction is present and not routinely. So, bronchodilators are used to treat the cough that is formed by bronchoconstriction, in simple words, but not routinely employed. They are used as adjuvants in some cases. Fixed dose combinations of centrally acting antitussive with the bronchodilator or with an antihistaminic that have high atropinic activity are banned in India. Now let us discuss some of the marketed antitussive and expectorant combinations. The first one is Astalin. It contains salbutamol 2 mg, guaifenesin 100 mg per 10 ml syrup. Dose should be 10 or 20 ml. The next is Ascoril C. It contains 10 mg of codeine and 4 mg of chlorpheniramine in 4 mg per 5 ml syrup. Next is Benadryl cough formula. It contains diphenhydramine 14 mg, ammonium chloride 138 mg, sodium citrate 57 mg, menthol 1:1 in mg per 5 ml syrup. By this we complete the drugs for cough. Thank you for watching. Please subscribe for further videos on pharmacology and other pharmaceutical sciences.